The hearing will come to order. Good afternoon and welcome to our witnesses and to everyone who is joining us for this first ever congressional hearing examining the global challenges in diagnosing, treating, and managing Lyme disease. My personal commitment to combating Lyme disease is long-standing, going back 20 years when one of our witnesses, Pat Smith, attended one of my town hall meetings in Wall Township, New Jersey, and asked me to get involved. I did. On September 28th, 2008, introduced a comprehensive bipartisan Lyme disease bill, H.R. 3795, the Lyme Disease Initiative Act of 1998. Which had at its core the establishment of a task force, an advisory committee to comprehensively investigate Lyme with at least 4 major areas in mind: detection, improved reporting, accurate diagnosis, and physician knowledge. I reintroduced the bill again in 1999, 2001, 2004, 2005, 2007, 2009, and have a pending bill that I introduced in 2011. I would note parenthetically that same year I also introduced a comprehensive law to combat autism. In the fall, with the support of, not opposition, but the support of NIH and CDC. If only we had done the same with Lyme disease legislation in the late 1990s, a missed decade on Lyme. As I have met scores of patients suffering the devastating effects of chronic Lyme who only got well after aggressive treatment by Lyme-literate physicians, I have been dismayed and frankly angered by the unwillingness of some to take a fresh, comprehensive look at this insidious disease. My current bill, H.R. 2557, simply establishes a tick-borne disease advisory committee, like we've been trying to do since 1998, with the requirement of ensuring diversity of valid scientific opinion, a, quote, broad spectrum of viewpoints to pull language out of the legislation serving on the committee. I would note to my colleagues that in Europe, Lyme disease syndromes were described as early as 1883, and by mid-1930s, neurologic manifestations and the association with ticks were recognized. In the United States, Lyme disease was not recognized until the early 1970s, when a statistically improbable cluster of pediatric arthritis occurred in the region around Lyme, Connecticut. This outbreak was investigated by Dr. Alan Steer and others from Yale, and stimulated intense clinical and epidemiologic research. In 1981, Dr. Willy Bergdorfer, an NIH researcher at the Rocky Mountain Laboratories, identified the spiral-shaped bacteria, or spirochetes, causing Lyme disease and made the connection to the deer or black-legged tick. Lyme disease is the most common vector-borne illness in the United States and is also endemic in parts of Europe and Asia, and recently has been confirmed to be endemic in the Amazon region of Brazil. In Europe, the highest rates are in Eastern and Central Europe. Recent surveillance studies have described growing problems in Australia and Canada. In the United States, Lyme disease has been reported in 49 states, all except Hawaii, and is most common in the northeastern and north central states and in Northern California into Oregon. Over 30,000 confirmed cases were reported to the CDC in 2010, making it the 6th most common reportable disease in the U.S. and the 2nd most reportable in the Northeast. CDC has estimated that actual new cases may be 10 times more than the reported number, indicating roughly 300,000 cases in 2010 alone. About 85,000 cases are reported annually in Europe as of 2006, according to the WHO, but that was recognized as a gross underestimate. In North America, the only Borrelia species to cause Lyme disease is Borrelia burgdorferi in Europe, and at least 4 other species cause the disease. Different species are associated with different manifestations of the disease. There are numerous strains of Borrelia which may affect the ability to evade the immune system, the ability to invade certain organs or tissues, and the responsibility and the response of antibiotics. Clinical manifestations of Lyme are usually divided into 3 stages, although the descriptions of the stages vary. Few diseases have aroused such a high level of emotion and controversy among the public, physicians, and researchers than Lyme disease. There are 2 distinct views of Lyme disease, each citing specific scientific evidence to support its claims, while outcomes research is limited and conflicting. One view, promoted by the Infectious Disease Society of America, is that the disease is, quote, hard to catch and easy to cure, and denies the existence of chronic Lyme disease or persistent infection with the Lyme bacteria. Any treatment other than a short course of antibiotics is considered too risky. Patients who do not fit the paradigm may have few options outside of psychiatric evaluation. The alternative view, promoted by the International Lyme and Associated Disease Society, and also by numerous academic researchers in the U.S. and around the globe, says that the science is too unsettled to be definitive, and there can be one or more causes of persistent symptoms after initial treatment in an individual who has been inflicted with the agent of Lyme disease. These causes include the possibility of persistent infection or post-infectious process, or a combination of both. These are not academic concerns, however, because the patient's health is at risk. Unfortunately, some academic researchers believe that some of their colleagues are more interested in winning arguments than moving the science forward. 3 areas central to the controversy are the quality of diagnostics, post-treatment, and available treatment options in light of clinical guidelines. Current diagnostic tests commonly used to detect the spirochete that cause Lyme disease, rather than detect whether the patient has developed antibodies to the pathogen. CDC recommends a 2-tier serological testing, but cautions that the 2-tier system could be used only for surveillance purposes and not for diagnosis. Part of the difficulty in clinically managing suspected Lyme disease is that the CDC protocol is frequently not only used, but required for diagnosis. Study in the Netherlands of 8 commercially available ELISAs and 5 immunoblots found that they had widely divergent sensitivity and specificity and a very poor concordance, and concluded that their, quote, very high variable sensitivity and specificity for other points puts the much advocated 2-tier strategy into question. In addition to the authors of the July 3, 2007 article on an antibiotic resistance element were Julie Bolin and Frank Giardani in NIAID's Rocky Mountain Laboratories, and they stated, it is a multi-stage disorder that is difficult to diagnose at any stage of the disease, as well as being difficult to treat during later symptoms. Dr. Mark Eshoo, the head of the new technology at the IBIS Biosciences Division of Abbott Laboratories, will tell us today some exciting information regarding the development of diagnostic tools that hopefully will move us past a lot of the controversy. Then there's the issue of persistence. IDSA has repeatedly stated that there is no convincing evidence that the Lyme Borrelia persists after standing antibiotic treatment. Convincing is clearly a subjective term, however. There is substantial evidence of the persistence of it after treatment with antibiotics. There are numerous documented case studies of persistence in humans after antibiotic treatment, and our witnesses may comment on additional evidence for post-treatment persistence in humans. Additionally, one of our speakers today, Dr. Stephen Barthold, one of the top experts in the country, and I'm sure in the world, on animal models. Dr. Barthold will describe published and yet to be published experimental studies that provide compelling evidence for the Bergdorf furry persistence following an antibiotic treatment in animal model studies and their potential significance for human medicine. Numerous studies have been conducted of the mechanism by which Borrelia may evade the immune system and antibiotics. Studies have suggested that resistance to antibiotics might be due to formation of different morphological forms of it, including cell wall deficient forms and biofilm-like colonies. Contrary to the known scientific evidence, in a March 21st, 2008 letter to members of Congress, the Infectious Disease Society of America stated, not only is this assertion that the notion that some spirochetes can persist despite conventional treatment courses microbiologically is implausible, there are no convincing published scientific data supporting the existence of chronic Lyme disease. It is problematic that the Infectious Disease Society of America would write to Congress trying to discourage support of legislation saying that post-treatment persistence is microbiologically implausible. Additionally, in an article, a chronic appraisal of chronic Lyme disease published in 2007 in the New England Journal of Medicine, several IDSA physicians and a CDC colleague made the statement that chronic Lyme disease, and this is a quote, which is equated with chronic B. Burgdorferi infection, is a misnomer. While this statement is referred to repeatedly in other correspondence, calling chronic Lyme a misnomer does not seem a reasonable or supportable, since it goes far past expressing uncertainty. It seems clear that the intent of the statement was to firmly slam the door on the notion that there possibly could be chronic Lyme. The final major area of controversy is the significance of the Infectious Disease Society of America's treatment guidelines, which directly impact patients and their ability to get treatment. Guidelines should be developed based on the best science, and there has been extreme controversy regarding the restrictive nature of the IDSA guidelines. The guidelines do not allow for the possibility of chronic infection and severely limit physician discretion on treating the disease. Finally, and I would ask unanimous consent that my full statement made a part of the record, I would point out to my colleagues that we did invite the Infectious Disease Society of America to be here, the NIH, as well as the Centers for Disease Control. We were told that the IDSA person who would have been here had a, quote, scheduling conflict, and I would just make very clear at the outset of this hearing that I will reissue an invitation to them and fully expect that they will testify before our subcommittee at a date that will hopefully be very, very soon. I'd like to now yield to Ms. Bass for any opening comments you might have.